Hello and welcome everybody to this evening's Shingles Webinar. My name's Susie Blackburn from the Immunisation Coalition. Just very briefly about our organisation, we have a mission to protect Australians against infectious disease. We use communication channels with current, easily understood and scientifically informed information in the hope of educating and providing public awareness for the importance of immunisation. Very warm welcome this evening to Angela Newbound from Adelaide Public Health Network. Angela is a much respected member of the IC and an expert on immunisation. Good evening, Amanda.
Hi, welcome everyone. So yes, as Susie said, Angela Newbound from the Adelaide Primary Health Network is where I'm based. But very, very happy to be a member of the Immunisation Coalition and support them with the webinars. So thanks for joining us and spending the next hour listening to my horrible voice. But at least this week we're doing very, very well because I should have good internet and we shouldn't be dropping out too much. So a pretty interesting topic is shingles. I think most of you would be very acutely aware of what causes shingles. It really is that reactivation of the varicella zoster virus. So when we all had chickenpox as kids, that virus has just laid dormant in our dorsal root ganglia, which we'll talk about shortly. But you know, this reactivation of varicella really is something that we see more commonly as we age. So that's one of the risk factors that we have. Obviously, the first risk factor is the fact that we had chickenpox disease. Second risk factor really is that we have increasing age. So every day that we're alive, we're getting older and older. Sorry to be the bearer of bad news, but certainly slightly higher incidence in females, and certainly if there's family history, but also if people are immune compromised or immune suppressed in any way, then, and we will talk about those shortly anyway. So as I alluded to, is the fact that once we've had chickenpox disease, the virus will stay dormant in that dorsal root ganglia. For reasons unknown to why it may reactivate later in life in some people, but not in every person, is a little bit of a quandary. But it's a very, obviously we know about chickenpox, it's a very infectious virus, so most of us have had that particular infection, and therefore most of us are, you know, certainly at risk of developing shingles later on. Interestingly enough, the degree of inflammation that we get with shingles when we develop shingles, there is an association really with the severity of the chickenpox disease that we had as children. And if we have severe disease with shingles, there is a correlation also that we are more likely to develop that post-hepatic neuralgia as the complication to Zoster infection. We have a couple of little polls that we have. So, Susie, I hope you can activate this okay. So, can shingles be transmitted from one person to another?
Okay, the poll has been, we'll relaunch it. There we go. The poll has now been launched and it's in progress.
So just select which you believe might be the right answer.
We've got about 50% who have voted.
Fantastic.
Looks like C is looking very popular here, Angela.
like C could be it.
We have got around about 80%, so we might close it off in a few seconds. We've only got a couple of people on A and B, but we've got 90+% on C.
Perfect.
And poll ended. I think we're done. Yes.
Lovely, thank you. So those of you that did choose C as your answer, you are absolutely correct. Someone with shingles cannot give somebody else shingles, but they could give a non-immune person chickenpox. Okay. If someone has chickenpox, they cannot give somebody shingles. All right. So shingles comes from within. All right. So you must have had your own chickenpox infection for that virus to be reactivated and come out as a shingles infection. Perfect. So, like we've just said, it can't be passed from one person to another, as in shingles, but certainly if somebody is non-immune and they do come into contact with the fluid that might be in the blisters, certainly they could contract chickenpox. So a good idea to just wait until those blisters and that rash has all scabbed over and it's nice and dry. The person's then no longer able to transmit that varicella infection to a non-immune person. Definitely keeping the rash covered and minimising the risk of that fluid contact is absolutely ideal. So we have these sort of, you can put a non-adherent padded dressing over. Somebody once asked me, can you use a Tegaderm or, something along that line. It's really ideal to keep the rash as dry as possible. So cover it just with loose clothing, or if it's weeping quite a lot and it's a little bit problematic, then most definitely it's okay really just to cover over the rash. Definitely, if anybody is non-immune or immune compromised, most definitely try and avoid being in contact with the fluid in those blisters. So most cases do experience this prodromal phase of 2 to 3 days, but it's actually not always present. So the presentation for shingles is not completely straightforward. It can really be very dependent on the signs and symptoms that a person does show. This zoster rash, usually, like I said, you've got this prodromal phase characterised by a bit of pain, a bit of tingling, but sometimes that pain can be really, really severe, and it's described often as a burning pain or a sharp stabbing type pain. And it's very characteristic in the fact that once the rash does appear, it's not really like a chickenpox rash, which appears all over the body. It's usually just limited to 1 or 2 dermatomes, and it's usually only on one side of the body. So it's only unilateral usually, rather than bilateral. So we have this appearance of a band of blisters. So it really depends on the dermatomes that have been irritated, but we do know that it is a self-limiting condition. It usually does go away, and usually people hopefully aren't going to develop too many complications, but we will certainly be looking at those complications. The most common complication that a person is at risk of developing is this post-herpetic neuralgia, or PHN. Some people get this acronym PHN confused with the Primary Health Network. Unfortunate. But in this instance, we are talking about post-herpetic neuralgia. So there's really specific criteria for that diagnosis to be made, and that is that the pain has persisted for longer than 90 days from the onset of the rash. So the probability of developing PHN increases with age, and that's really unfortunate, which is why this particular vaccine program that we currently have is targeted at the 70-year-old age group, not at the 50-year-old age group, where the risk of PHN is much, much lower. So this pain is very evident in the majority of people that have shingles. You can have a condition called allodynia, which is pain experienced by a stimulus that shouldn't normally cause a lot of pain. So that would be if somebody has a painful side, for example, they're complaining a lot of pain in their side, you might not even see a rash. But if you just gently touch it, or their clothes, just gently brush over their skin, it will cause significant pain. So very unusual. Normally you can wear clothes without pain, but this would cause quite significant pain. And this type of pain really can cause quite a lot of confusion. You've also got a condition that people can present with, which is dysesthesia, which is this really unpleasant, abnormal sensation. Either it's spontaneously there, or it's sort of provoked, and it's really this hypersensitivity as well. And because of the way they present with no rash, quite often, this pain is often confused with them actually having a heart attack, or renal colic, or cholecystitis. And usually once they present to an emergency department, they are usually the first investigations that really take place, is that something acute and perhaps surgical might be causing their pain. So it's really important to do a really thorough physical examination of these particular patients. And
just very quickly, Angela, on that, can you actually get the pain without the rash or blistering effect? Just a question from Lavinia.
Yeah, you can, absolutely. It's unusual. Most people will get the rash, but some people don't. And therefore, it's a real quandary when they do have this horrible pain and they do present at an emergency room or something like that. So it's important that when somebody comes with pain where there's really nothing happening on the skin, that perhaps one of the things that we need to keep in the back of our mind as a clinician is, could this be shingles?
Of course, thank you.
Yeah. So even if you just got something, just really, really, really light and brushed it over their skin, if they jump and pull away and ouch in pain, you'd have to be very, very suspicious that this could be shingles without the rash.
Great, thanks for the clarity. That's fantastic.
All right. So the problem that we have with post-herpetic neuralgia is that this pain is long-lasting pain. It is exceptionally difficult pain to control, even with opioids. We don't like giving opioids anyway to elderly people, but particularly opioids that still is not controlling their pain. So what we tend to see with these patients with PHN is it actually affects every part of their being, we see that there's obviously physical things that are happening. Obviously, in most cases, they've got a horrible rash that they could be embarrassed about. But we know that any infection like this will often cause fatigue. They don't feel that hungry, so that leads to weight loss. It reduces their mobility because they're in so much pain. Therefore, they're not physically active. They then find it very difficult to sleep for long periods of time, particularly of the evening, because they just sit all day and often have lots of little dozing sessions. We know that it affects their psychological well-being. Depression and anxiety settle in, emotional distress, difficulty concentrating on anything because the pain is just worrying them all the time. And they have a fear that this pain's never going to go away and they'll never get better. Then we've got the social part, where if you've got somebody that may still have a rash, but now has this horrible pain, they withdraw from their social circles. They tend to then become quite isolated. They start losing their independence and they change what their normal role in their social structure was. You know, you've got to remember that these people are no longer probably going to the shopping centre and having that engagement at a social level, but they're probably not even buying their groceries or doing anything like that to feed themselves. But then we've got the functional side where this pain will affect them being able to get dressed and to probably have a shower, eat, move around, you know, shop, do their housework, etc. So this is a really significant complication from shingles that we really want to try and avoid, and by vaccinating them we can certainly reduce the likelihood of PHN in these individuals, and we'll talk about that. Excuse me. So there's some other complications. Certainly if, it was once said to me by Dr. John Litt that if anyone presents with a shingles spot on the end of their nose, send them off to get their eyes examined. So they should really have an ophthalmic consult. Excuse me, just to make sure that it is not the optic nerve that is actually involved. We also know that with these types of inflammations, that patients are at increased risk of stroke and myocardial infarct. And we definitely know that the risk is increased in that 4-week period after shingles disease. So this is a serious disease. We do not want anybody getting shingles if we can possibly help it. So if you've got some patients who you have yet to convince to have their shingles vaccine in the catch-up program, hopefully being able to explain these additional complications and risks may well perhaps convince them that they should be getting the vaccination. So, like we were saying before, the majority of us have had chickenpox disease. Around about up to a quarter of us will probably develop shingles at some stage in our life. Most of the time that occurs over the age of 50. However, we do see shingles in young children, in teenagers, in younger people, but the likelihood is that it's going to be in somebody aged over 50. So for those people who have the advantage of a nice long life, they are at increased risk, most definitely, of developing shingles. And we've already said that those immune compromised individuals are also at risk. And we often see this in younger people when they're a bit run down, you know, perhaps they've had a cough or like a cold or a flu, a virus of some description, you know, their immune system's a little bit challenged at this particular time. You know, sometimes we do see shingles in those individuals. So it's a pretty costly disease, not only to the individual concerned, but also to our health dollar. You will see that the notifications look as though they are going up. Have they really gone up, or is it just that there are more people getting shingles? You know, are we just living to a longer life? Are we testing more, etc.? And I think there's probably a combination of all of those things. You know, whether it's, you know, when did it become a reportable disease? Is it reportable in every state and territory, etc.? So we do certainly see that shingles notifications are certainly coming in. If we look around the states and the territories, you can certainly see the numbers there. Queensland are doing very nicely if we've got anybody on board here from Queensland. And then us here in South Australia are tracking with reasonable numbers as well. So there is a difference in geographical spread, but is that related to concentration of older individuals, etc.? We have another poll. So, can you develop shingles more than once?
Okay, the poll's been launched.
We've got a few choices there.
Got a few people just still reading and taking their time. That's absolutely fine. About 50%, and it looks like D is looking like the most popular at 65-ish% at the moment, with some people thinking it may be B. And the voting's slowing down, so we'll give them a few more seconds. And 80% have voted, and here are the results. We've got 70-odd% down on D.
Okay. Well, the surprise is that the answer is actually B. So yes, we definitely can get shingles more than once, but it is actually uncommon. So one study will estimate that it is around about the 6.2% at 8 years. Other studies are similar to that. So, you know, the different studies that you'll actually see, there's not much difference, but yes, certainly a percentage of people will probably get shingles again, or may get shingles again, you know, sort of maybe around about the 8 years or so down the track. Okay.
Okay, I'll take that one off. Thank you.
So how do we prevent shingles or reduce the likelihood of somebody developing shingles? There are 2 vaccines that are licensed here in Australia. The one that we currently have access to is Zostavax. It is a live attenuated vaccine. In other words, attenuated means weakened. So in an immune competent individual, so a healthy individual, this vaccine is very safe and it should not cause any disease. So we need to be very, very careful with this particular vaccine being a live virus vaccine, and we will certainly be talking about that as we go down the track. It is available on the NIP for individuals at the age of 70, and currently there's a catch-up, and we'll talk about that as well. The other vaccine that is registered in Australia is an inactivated vaccine called Shingrix. So we probably might not see this vaccine for another couple of years, potentially. There is some discussion already happening to whether this vaccine may or may not make it onto the National Immunisation Program, the funded program. The difference here is that this vaccine is a 2-dose schedule. So therefore, potentially already doubled the cost. But it does have a bit of a different safety profile as well. So there are significant increased number of adverse events reported with Shingrix in regards to particularly localised reactions. More people will experience a big red swollen sore arm than they do when they have Zostavax administered.
And Angela, if a patient just gets the 1 dose of Zostavax, can they get a lesser breakthrough disease? Leonie's asked.
So at the moment, there is no recommendation for a booster dose of Zostavax at any stage. Now that might change in years to come, but yes, there is still the risk that somebody still may develop shingles. And we'll talk about vaccine efficacy in a little while.
Okay.
Yeah.
Thank you.
So we've got another poll. So you're all out there delivering Zostavax. So can you tell us, how is Zostavax administered? A few little choices there.
It's a fairly even split at the moment between 2 of the answers. I'm hesitant to say which ones at this stage, but we've got about 60% have voted. Give them a few more seconds. Okay, so poll ended, and there's the results. It looks like A.
All right, yes, correct. It is a subcutaneous vaccine, and it does need to be reconstituted. And generally the rule with reconstituted vaccines is that you reconstitute them and you administer them as soon as possible after reconstituting. Okay, fabulous. So this is a bit of a trick because you haven't been using Shingrix, you haven't been delivering this vaccine, but let's just see how you go. So how is Shingrix administered?
We've got a few confident early voters here.
Well done. Someone's been doing their reading.
That's right. Starting to get a split. Okay, so around about 70% have voted. We'll give people a few more seconds. A couple more to come in, I'm sure. And ending the poll in 3, 2, a couple came in, good. Here you go. Here are the results.
Oh, very, 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 very close. Okay, the actual answer, and you did surely well at guessing, the actual answer is B. It's actually an intramuscular injection, and I had already given you a bit of a clue that it was 2 vaccines, and it is 2 to 6 months apart for those doses. So we'll just wait and see what happens along the way with recommendations around Shingrix. Like I said, we're probably a little way away from hearing too much about that vaccine at this stage. So we'd really be encouraging all of those eligible patients to be receiving Zostavax. So we get down to the tin tacks. Who should we really be vaccinating? So the vaccine's really licensed to people over 50 years of age. When it's not licensed for younger individuals. As we get older, that risk of shingles increases. So, and at this stage, there's no, like I said, recommendation for a booster dose. So, yes, you can give it after 50 years of age, and then it's a bit of a wait and see to whether the recommendations will change. So, for example, if you've got a 51-year-old that comes in, wants to have a dose, certainly they can have a dose on private prescription. It's probably going to cost them around about $220 or so for the dose. So it's an expensive vaccine. Will they, when they reach 70, be given a free one? 20 years is a long time, and recommendations change on almost a daily basis. So who would know? Possibly there'll be enough data to say, yes, they do need a booster, or no, they don't. So at this particular time, Zostavax is on the NIP, the funded program for everybody at 70 years of age, and it will stay on the program for 70-year-olds. But there is that catch-up group, the 71 to 79-year-olds, through until October 2021. This is just so super important that you do your recalls and your reminders, and particularly targeting those people that are about to turn 80 years of age, because once they turn 80, they're going to lose that opportunity to have this expensive vaccine given to them free of charge. So if you have done all of your recalls and you've still got some clients that are still saying, no, I don't need it, I'm healthy, I run 25 kilometres a week and I play 3 rounds of golf, that's absolutely fantastic. But the problem is they are old, and therefore the risk is there for them to get shingles. So really talk to them about this, and just keep reminding them every time you see them. G'day, Jack. Have you thought any more about that shingles vaccine that I've been talking to you about? And you ask him that same question every time you see him come on in. Really important that we get this vaccine into these individuals to reduce that likelihood of them developing shingles, but developing post-herpetic neuralgia.
Now, Angela, am I right in thinking that a person can be vaccinated if they've already had a previous case of shingles at a younger age?
Yes, absolutely. People that have had shingles disease previously can still be vaccinated.
Great, thank you.
If they've had shingles disease fairly recently, the recommendation is that you would wait 12 months.
Yep, 12 months,
and
okay.
then vaccinate them, okay?
Great, thank you.
Okay, so we definitely need to be aware of people with these types of chronic conditions. People at higher risk of cardiovascular disease, we've already talked about that risk of stroke and myocardial infarct. It's quite interesting that the vaccine effectiveness or efficacy of the vaccine is not affected when we administer it to immunocompromised individuals. Now, this is a bit interesting in the fact that when we talk about flu vaccines, we know that flu vaccines, for example, or many other vaccines, do not seem to work as well in people that have got chronic diseases or some level of immune compromise. But this particular vaccine will work in people if they have chronic medical conditions, okay? So certainly we do not give this vaccine to the immune compromised people. There is a specific pre-vaccination checklist for Zoster. that every provider should be using before they administer any doses of Zostavax. As we said before, Zostavax is a live virus vaccine. It is similar to the varicella vaccine that we give to our children, but it is 14 times more potent. So for that reason, absolutely we must understand that our patient is well enough to receive the vaccine. So if someone has one of these chronic medical conditions and they are also immune compromised, you should not be giving them the vaccine.
And Angela, I noticed on the last slide there was a point about the 71 to 79-year-olds. Just had Anne ask about vaccines for over 80. Does the same apply for 80 plus?
Okay. So we can still vaccinate our 80-plus-year-olds, absolutely, but it's not free vaccine, okay? So they would need to have a prescription.
Great, thank you for that.
Yeah. So I do believe that DVA card holders, if they've got a gold card, then that gives them access to the vaccine cheaper, but they are not part of the funded program once they've had their 80th birthday. So if you've got healthy 80, 81, 82, 83, 84-year-olds, there is absolutely no reason why they can't receive vaccine, but it's just going to be on prescription. So this comes to our who should not be, and of course, you know, there's quite a lot of writing on this page, but it's people obviously that are immune deficient. They're either immune suppressed because of the medications that they are on, or they have a medical condition that has caused immunodeficiency. So your Zostavax pre-vaccination checklist will help you identify whether somebody is immune suppressed through treatment or not. So it will tell you the names of the drugs, the dosage, and the duration of treatment that would put an individual into an immune suppressed state. So please make sure that you're using that pre-vaccination checklist. Pregnant women are also on this list. Please bear in mind that this vaccine is only licensed for people over 50. So the risk that we will have of a woman presenting over 50 and pregnant would probably be fairly small, but stranger things have happened. So certainly if a woman does come in, we still need to ask that question, is there a possibility that they may well be pregnant?
And it looks like Hayley has just asked in the chat about, is it possible to give Zostavax to a 40-year-old with IBD and not immunocompromised?
For a 40-year-old, it's not licensed for them. GPs, of course, are able to write prescriptions off license if there's a good enough reason for that to happen. And that would need to be a very, very serious conversation that they would be having with that individual's treating specialist. So it becomes a multidisciplinary team discussion. But bottom line is the vaccine is not registered for use in Australia for individuals under 50 years of age.
Great, thanks for that clarity.
So before we vaccinate, definitely do that full medical history. Definitely make sure that you're using that pre-vaccination checklist before you administer any vaccine. Before you administer any vaccine, please check the AIR to make sure this individual has not already received a dose.
Now, Angela, people are wondering where they might be able to find that checklist. I know that the Immunisation Coalition will upload a PDF of this presentation to our website in the coming weeks. Is there a place that you know, in addition to that, that they might be able to look at that checklist for the medical background?
Absolutely. You will find the checklist on the Commonwealth Government website. So if you actually just Google Zostavax pre-vaccination checklist, it will come up straight away for you. You can also go to the NCIRS website, which is the National Centre for Immunisation, Surveillance and Research.
Yep, that's correct. Research and surveillance.
Research and surveillance, yes, I'm getting my acronyms, my words around the wrong way.
That's all right.
NCIRS website, but definitely it's on the Commonwealth website. It is also available on the Immunisation Hub website here in South Australia. So if you Google Immunisation Hub, all one word, you'll come to our website as well.
Awesome, thanks so much.
Otherwise, you know, in your other states and territories, if you contacted your immunisation program officer in your local primary health network, they would probably be able to direct where it might be on their websites as well.
Excellent. I've got a little comment from Kate who's adding to that MVEC website also has it, and the SAEFVIC.
Yes.
Apologies, but my acronym knowledge is not fantastic, so hopefully you guys know what those stand for.
Fantastic. Thank you so much for that. Yeah, look, you know, really the states and territories, there's lots of places that you'll find this, and seriously, just Google for it and it will pop up straight away in front of you.
Great. And for those in Melbourne, the Melbourne Vaccine Education Centre can help you out as well.
Absolutely. So really important that you're using that checklist before you vaccinate, but also, like I was saying, double check the AIR to see if this individual has already been vaccinated. There have been many dose 2s put onto the register already, and I do get a number of phone calls and emails from providers saying, oh my gosh, we've just given a patient Zostavax and then we've checked the register and there's one already there. So look, you know, I'm not 70, but gee whiz, I'm getting close. But, you know, I don't remember what I did 5 minutes ago. So I would not remember patients at 70, 75, 79 years of age are not going to remember whether they had this vaccine a year ago, 2 years ago, 3 years ago. So please, please, please have a look at the AIR. It's the normal standard rules. If we cannot find any documentation, then we assume the dose has not been given and we would go ahead and give it. So if this patient is new to your practice, please, with their permission, contact their previous practice and ask, is it written anywhere in their notes? Because it may not have been uploaded to the AIR. But if this person has been a regular at your practice, please check the case notes. Please check AIR. And the reason I'm saying that is when the AIR expanded back in 2016, unfortunately, there were a lot of glitches with the medical practice software, and not everything was transferred to the AIR as it should have been. So please just try and be a detective and really find out. And if you can't find any evidence, then certainly go ahead and vaccinate this particular individual. So this is the table that you will find, or you know, certainly very similar to what's in the immunisation handbook, certainly what's on that pre-vaccination checklist. And you'll see there exactly what I was talking about in regards to what is the therapy what is the duration of treatment, what is the dose of the treatment, etc. And that will help guide you to, can this person be vaccinated or not? If they can, when can they be vaccinated? So with Shingrix, this will play an interesting role potentially for those patients that currently are immune compromised and cannot receive Zostavax. This Shingrix vaccine would certainly be an option for those individuals. So it will be a very interesting journey to see how the Commonwealth responds once Shingrix becomes available in Australia. And it may not become available until the Commonwealth makes that decision and gives some guidance to the company that does produce this particular vaccine. So it is a non-living vaccine and therefore very much suitable for those immune compromised individuals. So we'll talk about Zostavax because that is the vaccine that we are currently working with. So we know that a number of years ago there was the shingles prevention study that was done. It was a randomised study, double-blind, placebo-controlled study in around about 38,500 adults that were all over 60 years of age. So they were randomised, some of them received the vaccine, some of them received a placebo, and then they were followed up for around about just over 3 years. So the end point really was that when you compared the vaccinated group to the placebo group, it was shown that the Zostavax really reduced the incidence of individuals developing shingles by around about 51%. So generally when we talk to our patients, we say to them, look, if you have this vaccine, it will reduce the likelihood that you'll develop shingles by around about 50%. So 50% of an airbag in a car crash is better than no airbag at all. So it does mean that even though they might be vaccinated, they may well go on to get shingles later on. But one would expect the same with our chickenpox vaccine, that they're not going to get it very severely. So but these particular individuals, the other thing that was really noted in this shingles prevention study was that in the vaccinated group, the Zostavax group, it reduced the incidence of that post-herpetic neuralgia by around about 67%. So now you might be able to see the picture a little better to why the vaccine is given later in life and not to individuals at 50 or even 60, because that risk of PHN increases as we get older. So the argument then is, why don't we give it to the 80-year-olds? Why are we giving it to the 70-year-olds? Well, it really is about quality of life leading into the older years. We're still unsure about booster doses down the track. And it really is around about those quality years of life that a person still has. And quality years of life, of course, on general rule, there are more of them for a 70-year-old than there is for an 80-year-old. So this was a really important study and exceptionally good news. So when we talk about this vaccine to your clients, please really think about the evidence that's behind this vaccine and how effective it is. So looking at vaccine effectiveness, just in regards to the different ages. So you can see the blue bars are the unvaccinated, whereas the vaccinated group are in the orange. So definitely reduced number of people that ended up with shingles in the vaccinated group. In regards to those people with the chronic medical conditions, and remember I spoke to you a little bit earlier about that we just actually don't see a reduction of efficacy in these individuals with chronic disease. So this is, you know, really good evidence that we should be giving this vaccine to people with chronic disease. And we will see that reduction in the number of cases of shingles in that group. So in regards to the comparison of Shingrix and Zostavax, and you'll see there that Shingrix has much better efficacy, so 90%. So if someone has their 2 doses of Shingrix vaccine, then they have got a 90% chance of not developing shingles, compared to the 50% with Zostavax. So really good data that Shingrix is a very, very effective vaccine. We look at the safety profile of the vaccine. We can see that Zostavax is quite well tolerated. You've probably not seen a great deal of unusual adverse events. We certainly know that some individuals will certainly get that sore arm, a little bit of redness around the injection site, feel a bit headachy, feel a bit tired. Really nothing more than other people feel with other vaccines. We certainly know that we can be very reassured when we're talking to our patients that the risk that, or the experience shows that the transmission of varicella virus, of the rash, occurs rarely to contacts if someone's been vaccinated. So I think we can be really happy to have further conversations, certainly with our patients. This is one of the questions that we often get asked, is can we give Zostavax on the same day as other vaccines? And that's an absolute yes, we can, and yes, we should. We certainly see that Zostavax administration increases around flu season. So we know that practices are out there giving a lot of flu vaccine, and it's kind of a reminder then to say, oh, have you had your shingles vaccine? Because we can do that on the same day. However, flu vaccine is seasonal. Shingles vaccine, you can vaccinate them anytime, all year round. So yes, you can give them on the same day. Can you give them with Pneumovax 23 as well? Absolutely yes. Can you give all 3 of those vaccines on the same day? Absolutely yes. But just make sure that you are separating your injection sites by 2.5 centimetres. If you're giving a live vaccine as well as the Zostavax, for example, because somebody's travelling overseas and they're having a yellow fever or an MMR vaccine, you can give them on the same day in opposite limbs. If you don't give them on the same day, you must separate those live virus vaccines by 4 weeks. With your inactivated vaccines, if you don't give them all on the same day, say you choose to give Zostavax and a flu vaccine today, 1 in each arm, but you need to bring them back for their Pneumovax 23, you could bring them back the next day. It wouldn't matter, all right? So between inactivated vaccines or an inactivated and a live virus vaccine, we don't need to worry about that 4-week interval. It's only with live virus vaccines. So then if we're looking at the Shingrix vaccine safety profile, we can definitely see, once again, it's a safe vaccine. However, much higher rates of injection site reactions and higher rates of the systemic reactions, such as the muscle aches and the feeling tired and the headaches, etc. So it's going to be an interesting decision for the decision makers to make in regards to where this vaccine may well fit into Australia and into our program. Like I said before, we absolutely need to get this eligible cohort vaccinated. We are probably sitting at around about a 60% uptake across Australia. So that's 40% of these older individuals have not yet taken up the opportunity to have this vaccine for free. So once again, I just really ask, identify your patients in your practice management software, do those recall reminders. If that means getting on the phone and actually phoning people so you can explain all of this information that I'm giving you tonight, then it could be a few minutes of your time that's well worthwhile. So recall, but every time you see one of these individuals coming into your practice, look at the opportunistic aspect. Please, if they've come in with an infected toenail, please let them walk out with a sore toe and a sore arm, because we've got to grab them while we see them and have that conversation with them. Treatment-wise, antiviral treatments, definitely for your patients that are coming in, so your immunocompetent patients that do present fairly early with the onset of the rash, definitely for all of your immunocompromised individuals as well. It's a discussion certainly to have with the individual, but there is evidence that a couple of those antivirals are more effective than acyclovir, particularly around reducing the pain. So there is a table in regards to recommended treatments, first line and other alternatives. Unfortunately for these individuals, some of them are going to go on and need things like oxycodone just in order to be able to feel as though they are on top of the pain. But sometimes, certainly, the pain is so severe that opioids don't even help control it. But certainly, they need fairly close supervision if they are on opioids. So with a minute to go, just concluding that we know that shingles increases, the risk increases as we get older. We know that we've got a very safe and effective vaccine available to us. We have a funded program, so we are really asking providers to do everything they possibly can, and I know that you've done a fantastic job with this program to date. We've got a little way to go. It's always harder to push a heavy cart up that last part of the hill, but we're just asking everybody to really try. Really look at those opportunities when you see these individuals, look at your recall reminders, definitely. Making sure that you use that pre-vaccination checklist before you administer any vaccines, obtain that medical history, be really thorough about it, and definitely check the AIR and have that early management plan of antivirals just to help with the pain for these individuals, because it's a dreadfully uncomfortable condition for them. Any
Thank
questions?
you very much. I don't think we have any further questions from the audience. We'll give them a minute if you like to just bring something up if they have something. Have you got anything further, Angela?
No, I think
All done.
I think we've covered everything.
You've done it brilliantly as usual, young lady. Thanks again, Angela, for a fantastic presentation. Your support is really appreciated by the Immunisation Coalition. Thanks everybody for attending tonight. Just to reiterate, we take a recording of this webinar. If you'd like to share it with those around you, it will be uploaded to the Immunisation Coalition website at immunisationcoalition.org.au. Probably in the next 2 weeks. We do need some time to get it all prepared for you. Otherwise, a PDF will be uploaded as well, and you can also email us through the website at any time. I encourage you all to please follow us and join up to our newsletters, bulletins and conference alerts, and get involved, and good luck out there with the positive message of immunisation. Thanks, Angela.
Thank you, everybody, and thank you for all the work that you're doing out there, and thank you for joining the webinar tonight. Thanks, Susie.
All the best to everyone. Thanks. Bye-bye.